So this week we've got second of our two Cancer Research UK people, more people coming in. Christine, so if you didn't see last week, Lucy did a chat last week and we're trying to get that edited so you can watch it again. Christine doing a talk this week. Christine also works for Cancer Research UK in their analytical team. Christine, I shall hand it over to you. Have you got some slides? You should be able to share them now. And we'll just let you crack on.
Thank you very much. Let me share those. Okay, lovely. Thank you very much. So welcome to my talk on cancer incidence by broad ethnic group in England in 2013 to 2017. My name is Dr. Christine Delon and I'm a senior analyst in Cancer Research UK. Great. So I'll just give you a quick overview of the talk. I'll be discussing what data we had before and why we carried out the analysis now. What context can we put the data in? How did I carry out the analysis, the method? What did we find, the results, and finally the discussion. So what data did we have before? So the previous analysis was carried out in 2009 by the National Cancer Intelligence Network, NCIN, with 2002 to 2006 data. Due to small numbers, we do need 5 years of data. And the percentage of people with ethnicity data available was relatively low in 2002 to 2006. So shown on this graph, the graph shows the percentage of people with missing ethnicity data. So at that time, the data or the cancer data collected by the registries, whether or not it had information about ethnicity for the person, around about 70% of the cancer patients did have ethnicity and around 30% of people were missing ethnicity data. And of course, we can't be sure which people are in the 30% missing. Is there any bias in the missingness? So the sort of large percentage of missingness means that the 70% of people that we do have data for, we're not quite sure what conclusions to draw from that. So now the data is much better. So from 2012 to 2017, we're looking at 90% complete and only 10% of people missing data on ethnicity. And if we note these data improvements in 2011 to 2012, this drop in missing data and the increase in good data was predominantly driven by Mike Richards in his role as National Cancer Director. He prioritized the completeness of ethnicity data in hospital records, as well as pushing for the capture of stage of disease, radiotherapy and chemotherapy data, and generally improving availability and completeness of the cancer data. So looking a bit at the context, I've got quite a short section here, and each of these points I've got a full slide on at the end of the presentation, so we can discuss that later if necessary. But we've looked in the scientific literature for various studies around different regions of the UK, so maybe the south of England or Scotland, different areas. But we do see differences by ethnicity in cancer risk factors. So for example, we see lower or similar lower smoking prevalence in some group compared to general population, lower rates of being overweight or obese, and we also see higher hepatitis or rates of infection with hepatitis or H. pylori, which are risk factors for liver cancer and stomach cancer respectively, and we see higher rates of those in some ethnic minority groups. Looking at cancer diagnosis, again, we also see differences in the base of ethnicity around various parts of the UK. So looking at screening, we see lower rates of screening for bowel, breast and cervical cancer for some ethnic groups, and differences in stage of diagnosis. So we see later stage of diagnosis for some ethnic groups, some non-white ethnic groups. And looking at cancer outcomes, the Cancer Patient Experience Survey has shown lower rates of satisfaction for people from non-white ethnic groups. And again, differences in survival, we appear to see higher survival in some non-white ethnic groups. And again, more detail on all of those in a slide at the back. So these are the broad ethnic groups that I studied. So in the talk, so we have the Asian ethnic group, the Black ethnic group, and people of mixed or multiple ethnicities, which for short, I may call that the mixed or multiple group. We have the other group and we have the white ethnic group. So one thing to bear in mind is ethnicity can be quite complex. So the experience might vary a lot for an English-speaking person versus a non-English-speaking person. The ethnicity may be assumed by the NHS and they may not have asked the person for ethnicity. And that doesn't mean if, depending on how well ethnicity data is being collected, this sort of, this other Asian or Asian unspecified, for example, might be higher. Like if people don't know which of the specific groups someone should be in, whether someone is Asian Pakistani, Asian Bangladeshi, and they just put them down to Asian, that those other Asian or Asian unspecified groups might have very high rates because a lot of people are being lumped into those groups. So these sort of subdivisions may also be less accurate if people are being lumped into the other group. So one benefit of these broad ethnic groups is that should be less of a problem. Yep. And one thing to note is looking at people of mixed and multiple ethnicities is that essentially this group is a children of the other groups. And we'll see later that this is a very young group. So the overall point is really how do we address ethnicity in data? So this is very sensitive data and it's helpful for the public good. And we realize that there is a context of institutional racism and lived experience. We need data to recognize if a community is underserved in order to be able to rectify this. So how can we balance personal rights with the needs of both local community and wider society? And how can we balance the needs of the NHS with the people they serve? So having provided a little bit of context of previous study and reason why we're able to look at the data now, we're coming on to sort of the preliminary results. So first of all, just looking at incidence data, this is summary level data and it provides a useful baseline for understanding cancer in England. So I've got summary level data, incidence data for all cancers combined for 33 different cancer types, and the previous study only covered 20 cancer types, for 4 leukemia subtypes and for 2 carcinomas in situ. So we can see that 88.6% of all of the cancer patients are in the white ethnic group, 2.5% in the Asian group, 1.7% in the black group, 0.4% of mixed and multiple ethnicity, 1.1% in the other group, and 5.6% are not known. And we'll be coming back to that not known later. So although it is the not known category is the smallest it's ever been, it is still higher than each individual ethnic group. So this is just an excerpt of the table. The full table is in the paper with all of the numbers for each cancer type. So one sort of useful aspect, even just of the incidence data, is, for example, a colleague said, oh, if there's a clinical trial of bladder cancer, how many patients should be recruited to the clinical trial to be proportionate to the number of patients in England? So if you're recruiting black patients to be proportionate to the number in England, you'd want 1% of black people in the trial. And conversely, it's also useful if you sort of said, for example, we want to recruit 20 people of black ethnicity to our clinical trial. We can see here that there's 63 people of black ethnicity in a year. So if you wanted to recruit 20, that's a third of everybody in that year. So depending on your recruitment criteria and sensitivity of how many people can be recruited to your trial, this would inform how many years you might need to collect data for. Looking at the methods, so we did not calculate rates where the number of patients were less than 105 years, which is less than 20 per year. So for example, going from very small numbers, we would have been less secure of the age standardization, which I'll come to on the next slides, and we would have had very wide confidence intervals in those. So the confidence interval is so wide, we would have just said, oh, they're similar, and we wouldn't have had any real information from those. And we also didn't calculate the rates where not known exceeded 10%, as we see here for cervical carcinoma in situ. So looking at the not knowns, the number of people with missing ethnicity data, the data completeness does vary by sex, cancer type, and sex. So we see a big outlier with very high percentage of people with not known ethnicity data for cervical carcinoma in situ and non-melanoma skin cancer. And those are at 30% unknown or 20% unknown. So it's interesting to note that these two outliers are both non-admitted care. So data entry is reduced when the patient is not admitted. And if we compare cervical carcinoma in situ with cervical cancer's got much less missing data. So we're looking at well over 90% completeness for data. So we really see that if a patient is admitted to hospital or not, that affects their data collection. So moving on to the methods, we had the incidence, the number of people of every cancer type, and then the next step was to calculate the rates so that we could make comparisons between the groups. So for that, we calculated the age standardized rates. So here I've shown you the population breakdown of each group. So the first group in the circle is a European 2013 standard population. So that's an artificial population used to calculate age standardized rates. The group here is a white ethnic group, which we see is quite similar to European 2013 population. And then at the bottom, we see the population breakdown for the Asian group, the black ethnic group, and the mixed and multiple people of the mixed and multiple ethnicities. And we can see here that these two population structures, these three population structures, sorry, are much, much younger than the white ethnic group. with much more young people and much fewer older people. So in order to calculate the age standardized rates, we calculated the rate in each of these 5-year age bands. And then effectively, we sort of stretch the data to say, if this population had the same population structure as the European 2013 population, what would their cancer rate be? So we're weighting the actual population and then weighting it according to the standard population so that we can have a number that's comparable even when the populations have very different age breakdowns. So of course, cancer being a disease of old age, with these 3 younger populations, we're going to have much fewer cancer cases, but that's because they have much fewer older people. So by taking age standardization into account, we can compare population. We sort of stretch the number for each population to say, what would it be if they had the standard population, so we can have a number that's comparable across different populations. So age standardization is, of course, very necessary when looking at long-term trends. So as the British population has been aging, cancer cases in older people have increased. So then it would be a question of, is cancer increasing just because there are more old people, or is it actually increasing? And when you have an age standardized rate, you can compare populations, different age structures. So that's always essential, but it's particularly essential for this study. So as I said, age standardized rates are calculated for each sex, ethnic group, cancer type. And then the rate ratio between the rate in the white ethnic group and each of the other ethnic groups was calculated with 95% confidence intervals. And the confidence intervals give a measure of whether the difference is statistically significant or not. So having calculated the age-specific rate for the 5-year age bands, we use the European 2013 standard population. We created the weighted total, that's an age standardized rate. And age standardization, as I said, takes the rate in the actual population and finds out what the rate would be if the population had the same age structure as the European 2013 population. And in this way, we can compare populations with different age structures. So before I get to showing you what the actual rates are, I'll be discussing limitations so we can see how sure are we of the results. So there's 2 main concerns, 2 main limitations, and I'll discuss each in turn. And that's the limitations in the base population that we use to calculate the rates, and in the cancer cases, particularly where the ethnic group is not known. So the base population that we need to say, what is the actual rate? So we've got X many cancer cases, but if we have the same cancer cases in a small population, a big population, obviously that'll affect the rates. So the census data from 2011 is a gold standard, but as I've said, we're using 5 years of data, so we're never going to be able to just be using the census data. We'll always need sort of data from years around the census data. So the data that we use is ONS aged on population. So they sort of said, okay, here's the number of people in 2011, we're going to add a year to everyone's life. We're going to make an estimate for the number of births, and then we're going to take the number of people who died that year and assign that to our population. So we know how many people died, so we can put that into our estimate, and then they just repeat that several times over for each year. But the question is, how do we know who moved out of the country versus who died? And importantly, ethnicity is not included in death certificates. So we don't know whether people in different ethnic groups are dying at different rates, if they have the same life expectancy. So the deaths were just assigned proportionately. So again, births are estimated, but luckily for cancer data, that's a disease of old age. Less than 1% of cases are in people under 15. So that's not really going to affect our numbers too much. And we carried out sensitivity analysis by changing the population and recalculating the rates. And then we asked, does that change the data? And I'll discuss sensitivity analysis on the next slides. We consider some other data sets. So there's a health survey data, but this excludes communal establishments, which excludes all people's homes. So if we have any doubts as to whether people from one ethnic group or a different ethnic group are more or less likely to be at home or in an old people's home, this would influence how reliable this data is. So we considered sort of doubt as to whether different ethnic groups are equally likely to go to old people's homes versus staying with their families. So we consider that data not suitable for this project. And FPOP is a useful data set which does take immigration into account. However, that only produces data at 5-year age bands. So we don't have the annual data for that one. So we carried out sensitivity analyses. We calculated the rates with the the more common cancers. We calculated the rates with the 2012 data, which is close to the gold standard 2011 census population. And we also made some assumptions to how the population might be different. So we changed the population in 3 different ways and then recalculated everything with these 3 different populations and then compared the rate ratios. So we assumed the population was different in a way of a white population decrease. So for this population, we took the 0 to 4 age group and the 90 plus age groups and subtracted 10% of the white population and distributed that amongst the other populations. Or we made a question about the white population increase. For all age groups, we took 5% of each of the other populations and added it onto the white population. Asian population increase for ages 0 to 64, we increase Asian population by 10%, and for ages 65 to 90, we increase the Asian population by 5%. And then we took those numbers proportionately from the other groups. And this was based on ONS comments, where they're saying, as regards aged on data, this was the population group that they were least certain of the data. So we wanted to do more analysis for that population. So having recalculated all the rates and comparing them to the rates with the unedited population, the result, the direction, and the significance of difference was essentially the same for all these different population groups. Looking at cancer cases, the main concern is a not known category. So data completeness is the best to date, yet people with missing data outnumber each ethnic group. So for example, if the not known group was for some reason, predominantly Asian or predominantly Black, then Asian rates or Black rates would be triple as high as we think. So this is just a graph of that. So as I showed you earlier, we had the not known group running at sort of 30% or higher and then dropping to under 10% from 2012. So the dark purple line in this graph is that line, which is off the scale at the beginning. And then we see that from 2011 to 2012, these minority ethnic groups all increased proportionately as data quality increased. But nevertheless, the not known group is still higher than each individual group. So one thing we did to look at this was looking at age distribution of the cancer cases. So in this graph, the white bar is the 60 to 65 age group. So all the colored bars below the white bar are the people under 60, and all the part of the bar above the white section are people over 60, over 65. So these bars are proportionate, so they don't represent, they're not saying, so for the non-white ethnic groups, they're much smaller numbers behind these graphs. So even though, for example, in the Black ethnic group, the 50 to 54 bar is larger than in the white ethnic group, nevertheless, there's a lot more people in this graph because we're looking at 270,000 people overall in the white ethnic group versus only just over 5,000 in the Black group. So these are proportions, not numbers. The bars represent proportions, not numbers. And we can see that cancer cases are in rough proportion to the base population. The younger populations has more cases in young people, and that would be the case even if the actual distribution of cancer was the same across all ages. So as I said before, the white ethnic group is the oldest ethnic group, and that has the most people over 65. Most cancer cases in people over 65, and the Asian, the Black, British, and the mixed and multiple ethnic groups are younger, and therefore they have more cancer cases in younger people. So the main point to note here is that the not known group is most similar to the white group. It's a much older group than it's got a much older distribution of cancer cases than the Asian, Black, or mixed and multiple ethnic group. So this suggests that the not known group doesn't have a disproportionately large number of non-white ethnicities. And the sensitivity analysis for the not known group was we took all the cancer cases not known ethnic group and assigned those cancer patients proportionately to each ethnic group by age, sex, and cancer type. And then we recalculated all the rates with that distributed data. And again, the results, direction, and the significance difference was essentially the same for all cancer types. So now I'm going to show you the actual rates that we calculated. So this is the main data table for single-sex cancers like breast or prostate. We have the single sex, but otherwise it's a person's rate here. So this is the rate ratio. So each bar, the purple bar is the Asian group, the black bar is the Black group, sorry, the blue bar is the Black group, and the pink bar is a mixed and multiple group. And a bar at 1 represents somebody, a ratio that's very close to 1, so that the rate in that ethnic group is very similar to the rate in the white group, where the bar is close to 1. It's plotted on a logarithmic scale, so 0.5 means a given ethnic group has got half the rate compared to the white ethnic group, and a bar at 2 means that ethnic group has got a rate that's double what it is in the white ethnic group. And 0.1 is if you got 10% the risk, so the rate of that cancer type is 1/10 what it is in the white ethnic group, and that's what we see for melanoma skin cancer. That's much less likely to occur in people of Asian or Black ethnicities, and nothing is 10 times as high, thank goodness. Each bar also has confidence intervals. So this bar here, looking at people from the Asian ethnic group with bone sarcoma, the bar goes a little bit above 1, but the confidence intervals cross 1. So that difference is not statistically significant. So the results show that looking at these cancer types, for example, prostate cancer is much higher in people of Black ethnicity than in people of white ethnicity, and that's double as high. And that one is the most important one because prostate cancer is one of the most common cancers. And due to prostate cancer, looking at all cancers combined, the rate for all cancers combined is lower for Asian people and for mixed and multiple people. And it is also lower for Black people, and it is statistically significantly lower for people from the Black ethnic group. But that difference is much, much smaller than it is the other ethnic groups. And that's entirely due to prostate cancer being higher in Black men. So for example, the all cancers rate for Black women, which I show in the paper, but I won't show here, is much closer to the other ethnic groups for all cancers combined. We see that gallbladder cancer is higher in people of Asian or Black ethnicity. Hodgkin lymphoma is higher, particularly in males of Asian and Black ethnicity. Liver cancer is higher in people of Asian and Black ethnicities, and this can potentially be related to higher levels of hepatitis. And we see stomach cancer is higher in people of Black ethnicities, and again, potentially this may be related to higher levels of Helicobacter pylori. So the evidence we have of that isn't specific to Black people, but it's specific to just some ethnic groups, but that may potentially relate to stomach cancer. And thyroid cancer, again, is also higher in people of Asian and Black ethnicity. So in summary, we found that the incidence rates of most cancer sites and ethnic groups and sex combinations were lower in non-white minority ethnic groups compared with the corresponding white group. Exceptions included prostate cancer, myeloma, several gastrointestinal cancers, and Hodgkin lymphoma in males, and thyroid cancers. Sensitivity analysis did not materially alter these results. So these results should galvanize efforts to better understand the reasons for this variation and the possible impact on cancer services, patient experiences, and outcomes. It's also worth bearing in mind that although cancer rates appear to be lower now, they may increase in the future. So even though rates are currently lower, observation of previous migrations suggests that the cancer rates of immigrants will grow to match the local population in a few generations. If rates do increase in other ethnic groups in the UK and rates become similar and are combined with the currently observed worst patient satisfaction, the situation in the future may be worse than it is now. And looking at the results in context, this can relate to cancer risk factors, so such as smoking, being overweight, obese, and infections of hepatitis H. pylori. And this raises the question, how can we influence risk factor prevalence? There are screening differences for bowel, breast, and cervical cancer, so that raises questions about how we can affect screening. The stage of diagnosis varies, so how can we deal with barriers to presentation? And as I mentioned before, we see differences in cancer patient experience survey and in survival. Survival is, of course, difficult to measure because, as I said, in order to do this analysis, I needed to have the population data by ethnic group and by 5-year age difference. And in order to calculate survival, we need a life expectancy by ethnic group and by 5-year age band. So that makes survival more difficult to measure by ethnic group. But CADIAS is working on producing a report this year. So other work by CRUK, we have our team also wrote the paper on stage distribution by ethnic group that I've been mentioning in the previously, and I got the link there. And we're developing an internal inequality strategy, which will include ethnicity, and we have CIK Talk Cancer. So CIK Talk Cancer teaches leaders in communities to have impactful conversations about cancer risk and the importance of early diagnosis and screening in their communities. Talk Cancer tackles misconceptions about cancer, helps reduce the stigma around talking about cancer, and breaks down barriers in seeking help. And Talk Cancer has carried out cancer awareness workshops in Urdu, Punjabi, and Arabic to date with support of local interpreters. And I've got their contact details there. So thank you for listening. Questions and discussion.
Christine, thank you for that. That was a heck of a lot to get through. Do you want to stop sharing your screen now, and then we can probably see people's faces? Just pick up the question first of all, which Brenda asked about who codes the ethnic group. So the ethnicity coding data you've used comes from the Cancer Registry, and the Cancer Registry predominantly will get that from hospital coded inpatient records. So I suppose the question comes down to who codes the data when you get admitted as an inpatient. That might be an unfair question for you.
Yeah, I'm not pretty clear on that, but I believe it's hospital staff as sort of they go about. So staff. So I think we were thinking that we don't know exactly how it's done, and we don't know if they ask the person or if they assume the ethnicity. So yeah, I don't exactly know how they calculate that. But it's also to some extent, there's linked data. They are collecting them from lots of different records. So if they're sort of not recorded in one place, but ethnicity is recorded in at another time, that will all be drawn in to the data.
So I'll come with you in a minute. So just on the coding, so you're right, the coding is determined by how the hospital staff do the coding, but so the coding comes through the hospitals, and the staff can only code what they can see. It really depends on individuals whether they'll talk to the person and say, could I assure ethnicity? I don't know whether there's been a study done on the way people behave in hospitals. Ethnicity data also exists in lots of other places. So as you said, it exists in some of the screening services. It exists on GP records. So there are lots of places where screening and ethnicity could exist for me. But the issue we've got really across the patch is they're not all linked together. So sometimes it's difficult to find.
And I wouldn't think they have access to GP records.
No. So yeah, but we'll come back to a whole topic on access to GP record data, but they wouldn't, from a registry perspective, they wouldn't, no. So I think Nanette had got her hand up.
I just very quick question I'm interested in. All this statistic and this are fine, but when you come, and it's mostly about people from different cultures and different countries. Now, if you compare it with maybe a slightly smaller or continental country where people have to more, adjust to their lives, there's a food, same everything else, is the statistic still the same? That's, I know men get more likely prostate cancer and burn from certain countries, but when people adjust themselves as much as possible to the environment they lived in, would this go down in incidence, or would it still be the same? What I'm trying to say, is it mostly genetic, inherited, or is it due to how you live, what you eat, and so on, and the environment?
I mean, I think some of the main evidence is from sort of Japanese people immigrating to America. So Japanese people currently have lower breast cancer rates, and Americans currently have higher breast cancer rates. And Japanese people who moved to America in the first generation had lower breast cancer rates, but 2 generations later, their breast cancer rates are the same as Americans. So according to that, it would be behavioral. Of course, skin cancer, the lower skin cancer, that is genetic, but that's one of the only things that are sort of genetically different, really. That's a sort of just skin. So yeah, the skin cancer one is genetic, of course, but the assumption would be everything else would be behavioral.
Thanks, Christine. Stuart, you got your hand up.
2 or 3 points, sorry. Firstly, you don't ask people's religion, do you? In some cases, if you look at something like the Jewish population, they have a much higher incidence of breast cancer and pancreatic cancer because of the BRCA gene. So that to me is something that you might want to include in the future. I do a lot of work for cancer charity. We look at health inequalities and reasons that people don't come for screening. one of the things in the Muslim community is that a lot of them believe that if you have cancer, it's been given to you because you've sort of sinned, and therefore they don't come forward and talk about it, which is kind of strange. And there's other factors as well that influence these studies. For instance, I don't know if it's linked, but the ethnic populations in Bradford have the highest rate of mouth cancer in the country. They also have the lowest rate of dentists per head of patient. So what I'm saying is there's a lot of other factors that are important. And the other thing, like I ask every time, you have all this data, what are you actually going to do with it? That's the question. I accept it. I'm not scientifically minded, and quite a lot went over my head, but there's a lot there. When you have this, what are you actually going to do with it?
That's a nice challenge. Let me just cover the first question to start with on the, because it's a good point you raised about mouth cancers and low numbers of dentists. So you may have come across this phrase called population health management, which seems to be going around the NHS quite proliferating these days. And this concept of population health management means, as a health community, you can look across a whole piece, whether it's Bradford or whether it's Sheffield or wherever, and you don't just look at health data. You need to understand the whole characteristics of the population and the structure of infrastructure you've got. And in fact, if you look at population health management, they would see the availability of dentistry and mouth cancer as one big package. So they may begin to look at those things when trying to plan and deliver increased dentistry service, or even ask for more money to deliver them, or whatever it is. So as we get more and more data, I think that's where this whole concept of population health will fit in. We maybe need to do a session on, get somebody who does population health for a living to say, what the heck is it? Maybe I could see some people nodding. Thank you, Brenda. Brenda always nods at my good ideas. That might be something we could pick up. The other point about where data like this gets used is it does get used in planning. It gets used in whole sets of communication type activities. So if we know that certain types of people, and we know everybody's an individual, but if certain types of people don't respond to screening calls, there may be people need the evidence to say, do we need to do more active management of active promotion of screening services and other things. So the data that gets produced from research studies like this and analytics such as this get used by a whole bunch of people. And you could argue it's not just the job of CRUK to use this and do good things with it. But anyway, sorry, I'll shut up now. Christine, you talked across you there.
And I think part of what my job is to tell other people about the data so other people can do something. That means you guys need to do something about it. Yeah, it's tricky, really. But partly, yeah, as I said, put the data out there, let people know what the numbers are so that they can be used for planning structures, planning activity. Yeah.
Just a point to come back on. I worked in Leeds with the Jewish community on the BRCA gene. And one thing that came out is like, we try and target populations. The only way you can do it is by actually direct interaction with them. So it may be of interest to you, but when we launched BRCA Journey, which was raising awareness of the BRCA gene, we did it in the synagogue on a Saturday with the population there. And the one thing that pleases me is I find it difficult because a lot of the work I do, I can never see any feedback or positive outcomes. But in the 5 years since we did it, several women have come forward, found to be positive for the BRCA gene, and obviously taking either surgery or whatever with it. But it's just that it is quite useful. I know it is complicated, and in terms of we are trying. My chance is to actually widen our talks. We gave one the other night to people who are hard of hearing, who have sight problems. These are all people who basically don't do well. People also with from different communities, like the Romani community. They're another community of people who don't engage. But yeah, thank you.
Yeah. Thanks, Stuart. I'll go to Richard Ballaran next, and then on to Brenda, if that's all right. Richard.
Yeah, I mean, obviously there's great wealth of great value in all this data, and of course how we're going to apply it is very important. I wonder, is there an overarching sort of body that looks at integrating this sort of data with, for example, I was recently attending something in which satellite imagery is used to make assessments of poverty, and also you can interpolate health levels quite specifically. I mean, who's been working on this, for example? So I was wondering if this could, be linked in with that sort of data to get even more useful? And is there a body that's coordinating this? Because there's an awful lot, and how you actually turn this to policy is difficult. But if you can actually coordinate in the first place, that would be very helpful.
In terms of linking other types of data, this would need to go by postcode data, I think. So, of course, we don't have access to postcode data at all. But, for example, the ONS produces neighborhood level breakdowns of poverty. So every neighborhood or lower layer super output area in the UK has got a location with a map, and then you sort of every single one of those is judged, I think, based on the census and updated data, is ranked according to deprivation on 5 different measures of deprivation. So for every single neighborhood, you can sort of say, are they in, you can put them in deciles or quintiles or any other amount of differentiation, and then you can say, okay, given their postcode, they are in this deprivation decile, so therefore, and then carry out the analysis by deprivation. And so that's something you can request, is the data by deprivation. And we have done some work on that as well, just in quintiles. And yeah, asking for ethnicity and deprivation, that would be another whole study. So I think what's slightly interesting about this is huge amounts of data, and there's a huge amount of things you could request, a huge amount of things you could look at. So for example, I showed you the difference in data completeness by cancer type, and that I feel like that could be a whole different study. You know, do different departments have different cultures of data collection or something? So part of, I think, what's quite useful is almost saying, this is, I have limited time, so I have to sort of, it's better to do a smaller study that I get published than to do a million studies that never get published. I mean, actually the data analysis was perhaps 10 or 20% of the work of producing the paper. So there's sort of a lot, I was racing ahead of data analysis thinking, wow, this paper's nearly done. And it was not nearly done. So part of the problem is there's huge amounts to look at, and it's a lot of work to boil it all down and write it up and publish it. So you sort of have to take that into account as well.
I think there's a few that I was going to mention as well. So if you're looking at, if you ask the question, who coordinates all research activity, who decides what gets done? Well, that comes down to research funders, and academics have to bid to research funders, and research funders will advertise that funding is available for particular topic areas. Some of those points about geography and air quality and a whole bunch of other stuff might actually fit within the population health world, which I've written down as my next job to do. Yeah. The other point I was going to mention was that the work Christine's done was looking at ethnicity. If, as an example, if she was to go back to the Cancer Registry from whence the data came to say, oh, could I also have a deprivation code, whatever it is, an extra piece of data? The process of going through that and asking for the extra data could add another 6 to 18 months to get the data in the first place. So I think that's why the researchers and other groups have to be very, very specific about what data they want and what they're trying to show. The ability to go back and say, oh, could I just add this on because we've forgotten it, is can be incredibly laborious. And often just doesn't happen. So that's just the elements of reality, really.
Yeah, you got to plan it in the scheduling, sort of, so you ask for this set of data for this particular purpose. And you also delete all the data afterwards as well. So if you wanted me to go back and reanalyze something, actually, we have the data for the purpose of this paper. And then when we've published the paper, we sort of made sure the data was safe when we published it, and then we published it, and then we deleted all the data. So in a way, that's also quite good because you actually have new projects and new work to get onto. So, but we don't have the data to reanalyze any of this. You'd have to re-request it as a new project. And then of course that would be more recent data, and the data would be slightly refreshed and slightly better if you did request it.
And just to be clear, when you talk about the data, for any individual patient, you don't see their name, their address, you don't see their postcode.
Right.
I think you just see them as simply as a number and a code, really, don't you?
Yeah.
Okay. It's just something that's worth mentioning for anybody new to this. Brenda, sorry, I've kept you waiting there. Brenda, go for it.
One question, two questions. One, I think Christine's just answered, and that was, is this information still confidential, or has it been published? And I think Christine said it has been published. In which case, could you send us the link to the full information as well as sending the slides, please? And presumably we can pass that on to anybody else who's interested.
Yeah, we can send the link and the PDF paper as well. Yeah.
Yeah. The other thing I was wondering whether, if you're asking patients about their ethnicity, I mean, I don't know whether we have got a standard definition of ethnicity, but I wonder if patients misinterpret it differently. I won't say misunderstand it. I mean, is ethnicity the same as race? Do they think of their ethnicity, as somebody mentioned earlier, in terms of their culture or their religion? And I remember a time when I was taking people, admin job, taking people's details. I think it was ethnicity or race. I can't remember which they said. And somebody said, "But I'm Arab, and that's not on the list." So maybe, I mean, I don't know whether you could tell me whether Arab is, a separate ethnicity, but I think sometimes we're in some countries where people are very much intermarried. They could say mixed, but to them it isn't mixed. It's a category that's missing. So I'm just wondering whether maybe Chris could send us a definition that we can think, for us to know exactly how ethnicity is defined. And is ethnicity the same as race?
So first of all, ethnicity is defined. When we all fill in our census documents, we all record ethnicity. So there's a standard set of definition codes. In fact, if you look across
the same thing, sorry, that's not what I'm asking. I'm not asking for a list of them. I'm asking for a definition. And is it based on what your colour of your skin? Is it based on who your parents were, or your grandparents? A list is not at all the same as a definition.
Yeah.
Thank you.
And I wonder about that myself, and I flip-flop because genetically I'm completely European. I'm part Italian, German, Swiss, and Romanian. So, but I'm born and bred in Britain. So I have always wondered, do I put myself down as white European or white British? And I've sort of changed my mind about that as well. But then part of the advantage of looking at broad ethnic groups is looking at top level ethnic groups that all gets sort of absorbed together. So for white ethnic group, I'm clearly in that ethnic group, whether I'm European or British. So some of that is merged when we have the broad ethnic groups, but it's a really good question when you're looking at the more different groups within ethnic groups, and you try to do breakdowns of that. And one point there, looking at the really small ethnic groups, or groups that in the UK are small, is looking at this sort of population level. For a lot of the cancer types we looked at, for a lot of the ethnic groups, we had less than 100 people a year, and less than 100 people in total, less than 20 people a year, and you sort of can't really do any significant statistics on that. So if you have really small numbers, you can't do the statistics. You'll just be like, oh, it's not statistically significant, or the confidence intervals are so wide. So from the point of view of a study at this level, the really small ethnic groups, kind of statistically speaking, we can't do much analysis with them. And that's also why we didn't present the other data. Like, we calculated it all, but like, who would other be? What would other mean? What would be the meaning of saying, oh, others, who is other? So we sort of focused on the groups that people can talk to, as opposed to sort of, and we didn't present results on other, because we're like, who would that be aimed at? Who would that be for?
So I think I'm going to challenge Christine, Matt, and Lucy to figure out if we've got a definition of what it means by particular ethnicity grouping. But I'm sure it must be somewhere. You can take that away some homework, and we can circulate that round. The other point I would make is, for the first time I came into contact with ethnicity data in health was probably 30 years ago. And the researchers at the time were using ethnicity derived from your surname, sometimes your maiden name, because that was the only way they could do it. So at the moment, now we've moved on, we've got a coding of ethnicity, but you're clearly demonstrating that a single code may not be applicable to a particular person, because we're all mixed ethnicity and race. Yeah. Your question about ethnicity and race, I'm not bright enough to know that, but we did do an education session about the different equality dimensions, where I think we covered some of that in there. So I'll try and repost that link when we email out with these other bits for you.
And one thing to bear in mind about name analysis is that there are sort of programs that will sort of run through all the names. I mean, that would be within the cancer registries, and we would just have the result of that analysis. But you can run all the names through and say, oh, this name is probably in this ethnic group. But the thing is, that differs for different ethnic groups. So some ethnic groups have names that are very similar to the white ethnic. Some non-white ethnic groups have names that are very similar to the white ethnic groups, and some ethnic groups have names that are very different. So if we did this, you probably could, to a large extent, pick out all the Asian names, but you probably couldn't pick out the names of people in the black ethnic group. So if we were to run this analysis on the not knowns, and then we're only picking out some of the people but not the other people, that would make the Asian ethnic group maybe more complete, but the black ethnic group equally incomplete. So although some name analysis is possible, we sort of deliberately thought it would just make things more confusing if we're only picking out a subset of the not knowns, and we're better to have the not knowns, the organic not knowns as they are, because hopefully that's a hospital thing and is not specific for specific ethnic groups. Whereas if you do name analysis, you definitely have different amounts of known and not known by ethnic group.
At the registry don't do the name derivation of ethnicity. They stopped doing that 20, 30 years ago. It just was unreliable. Stuart, you got your hand up.
Yeah. Do you get accurate information? Sorry. Do you get accurate information from the private sector? When people are diagnosed with cancer and they go to a private hospital, do you get the information from them ultimately, or does it come via the GP? And the second question is, just another factor is, do people from different groups do better because they have private health insurance and basically therefore they have better access? I'm not sure you know the answers, but it is interesting. But I have been told from people I've worked with that getting accurate information from the private sector can be difficult. That might be a way that your results are skewed. And the final thing is, if you're looking at Jewish people and trying to sort them by name, most Jewish people anglicized their names after the war. My name is Manning. My father's name was Zemansky, but because of all the pogroms and things like that, they changed their names to anglicized names. So that definitely wouldn't work. That's just something of interest.
Do you want me to answer the first bit about cancer registration? Because I used to be national coordinator for registries, so I should know a bit about that. So the data that arrives at the registry from the private sector is generally only for work undertaken in the private sector, but paid for by the NHS. So it's quite unusual for a private hospital to release the data of their privately paid for patients to the cancer registry. There were some talks about doing it, but I'm not sure that's robust yet. So that would be missing, which means you wouldn't be able to answer if people do better or differently after private care than other things. That wouldn't be reliable yet. You couldn't do that yet. Then the point about names is, ignore the comment about names because that was 30 years ago. That just doesn't happen anymore. It's just so unreliable. Don't know if I missed anything then. Nanette, you got your hand up. And there's a couple of questions in the chat which I can pick up in a second.
I just had to smile because in my young days I traveled a lot and I'd worked in different countries, and I grew up in Switzerland, so people were nosy obviously with my accent. Where do you come from? And when I said from Switzerland, I stopped that. You know, they used to make a comment, I must be very wealthy because all the Swiss are very wealthy, aren't they, nowadays? And it started getting on my nerves. So I used to say, well, what are you? Where are you from? I said, I'm human. And that used to shut them up. No, where I come from? I told you I'm human. What does it matter where I come from? You know, and a lot of people stopped asking me. And I still have it done with working with patients who wanted to know, where's your accent from? Oh, you come from Switzerland. Oh, it's such a wealthy country. I didn't see much of the money, actually. I was always a bit short. And so, yes, it's always, if you don't want to say, I'm human, and that shuts people up because people are just plain nosy.
Yeah, I get the same when I say I'm from Yorkshire. People don't ask me any more questions after that. There are a couple of questions in the chat. Emily was saying, is there a collaborative or population research that works like Christine's done, get overtaken but built on? Yeah, I mean, there's a whole set of research community out there. The research world is across academia, across the universities, particularly and across the charities, is really, really strong. So generally people can understand what's going on. Frankly, that's why research papers get published, because other people read them. They can trust them because they've been peer reviewed, they've gone through an appropriate process, and then that sort of generates the production line of research generally. That's probably the best way to answer that. Abby said the validity of white European type ethnicity group, which clumps white, Italians, gypsies and travellers together. I think you've covered some of that, Christine. The ethnicity coding we've got is pretty much a lumped together way of categorising people at a broad level. Any individual might not fit with any of the ethnicities coding that's available. But to try and do this sort of large scale research analytics across the country to give you a picture, that's generally why ethnicity coding is used.
Yeah, it's a bit like some sort of pixelated picture. It's got really big pixels, but you just sort of get a rough idea, rough outline. And it's just hard to get the data for a smaller level, and then all the confidence intervals will be so huge. You'd be like, say, well, we don't know, it looks higher, but it's not statistically significant. Yeah, it's just sort of the best you can do with the data you have.
Okay. We've only got a couple of minutes left. I was going to make a suggestion, unless anybody's got a question they want to put in the chat or wave at me or do whatever. There are a couple of things that seem to come up from this. One is we're going to need to run a session on what we mean by population health management, how this data gets used really within our populations, within our cities and communities. I think it would be a really good one to put together. So that's on me to do that. The second is there was a heck of a lot of statistical terms in there which people find difficult to understand. And we did touch on this in Lucy's session, and I mentioned we've done a bit of work around what we mean by statistical terms, but I think that's something that we could work with Cancer Research UK and to do something around. Could you explain what you mean by a rate ratio and why it's important and where we use it and all these different things? So it might not be a session which gives you all the understanding you need, but at least you get a grip of why certain statistical techniques are used and where they can be useful. Oh, Lucy's put her hand up. There she is. She took the bait.
Yeah, just to say it won't be, I guess, fully comprehensive, but we do have a page on our web pages already of like common cancer stats terms like defined. So we could link you to that definitions page in the meantime, if that's helpful. Yeah, that'd be helpful. And we can circulate that around to everybody who's been on this. And if we think that's worth a session in its own right, we can ask some questions about it. Then I'm sure we could put that on. And I think that might be the rest of my list. Did anybody else have any other point they wanted to flag or questions? Because if not, it'd be quite handy to know how these sessions go, because we've done, Lucy came last week, Christine this week. This is the first one we've done talking in one of our education sessions with somebody who's actually using the data for them to say what it is they're doing, and hopefully what's it mean, how do we use it. It seems to me it's sparked lots of different questions, but if it's not useful, then we won't do them no more. If it is useful, or if you want it changed, or if you think we should do more or less of, just let me know, either me or Alison or anybody, because yeah, we continue putting these things together. Brenda, did you put your hand up just then?
Yeah, just a thought from what you were saying about definitions. Has anybody done any research into asking people who other people think of ethnic minorities, how accurate that person, not accurate, how much the ethnic minority people can state their ethnicity in a way that is similar to what it's coded as, if you see what I mean. One of the reasons I asked in this is, from the little I've done about going into ethnic communities, I've heard that the translation very often means different things to different people. I mean, the example I was given particularly is pins and needles. When somebody's got a diabetic foot ulcer, they get pins and needles in their feet. But pins and needles translated to ethnic communities is not even what we would understand medically by a symptom. So I'm just wondering whether, and I've one or two other horrendous explanations of where something gets translated, but because of the culture or because of the religion or whatever reason, it doesn't mean to other people what we think it means. And I think this might be quite a big area of, you know, hopefully the results would show that we are getting the interpretation that we think they're getting, but we might not be. And I think that might be worth, you know, it might have already been done. That's what I'm asking.
Yeah, and I don't know. I'm not sure if any others on the call know whether that's been done or not. I suspect there's probably some significant charities or groups of government which look at those sort of things, but I don't know off the top of my head, Brenda. We'll have to see if we can find out.
Yeah, thank you.
Yeah. Okay.
It's only important if it's not right, if you know what I mean.
Yeah. Fab. Okay. I think we probably killed all the questions there. Plus, we're coming up to bank holiday weekend now. Yay! I'd just like to say thank you to Christine for this week, and for Lucy and for Matt for arranging these as well. I think it's really interesting. I think it's a dynamic which we could probably find useful to keep going, I think, as work progresses. Even one thing I suggested to Matt and the team was, when ideas come into CRUK saying, oh, should we look at this, or wouldn't it be interesting to look at this, they can use groups like us to say, here's half a dozen ideas that have been thrown at us. What do you think? So there's a range of ways we could use sessions like this.
Well, as I said to you last week, I still think if you're having a meeting, I mean, I know it's an hour or whatever, I still think having a 15-minute focus group where 4 or 5 of us can talk, I think would achieve a lot more. You know, I find it useful, and and then you keep having to put your hand up, but you're in a group, and you might ask the 2 groups to discuss different things. But I personally think, not only the participants will get more answers, but I think you would get more answers. You might stay half an hour through, right? Well, the main thing that this has brought up is, so let's go into groups to discuss it. Yeah, that's what I would do.
Oh, sorry, Stuart raised this last week for those not on the call, and at the minute there's only me running these because we're just waiting to get a couple more people employed. But that's on my list, absolutely, Stuart, to put together. Don't worry. Lovely. Right. In which case, I shall say thank you to everybody. Thank you to the CRUK crew for spending their time and putting their time together to do this. It's been much appreciated. Have a nice bank holiday, long weekend. Enjoy the sunshine.